It's not the gold medal. Good evening, everyone. Lovely to see you all here this evening. For those of you who don't know me, my name's Andrew Zanatino. I'm the Executive Dean of the Faculty of Health and Medical Sciences. It's a real privilege to be here this evening. Before we begin, I wish to acknowledge that we meet on the land of the Kaurna people, the traditional owners of lands in which the University of Adelaide's 3 campuses are located. Manu Nadlu, Tampinti Nadlu, Kana Yatinga Imperenti. So just acknowledging that indeed we are here on land for which we're gathering here. And I'd like to warmly welcome you to this evening's public lecture. We're really thrilled to have you attend this very special public lecture. Before we begin this lecture, it gives me a great privilege to, great pleasure to introduce Nino Desisto. For those of you who don't know Nino, Nino is the chair of the Northern Community Health and Research Foundation. And despite his appearance, he actually has 45 years of experience in aged disability and healthcare sector in rural and metropolitan South Australia. So when you see him come up on stage, you'll think he's probably about 45. So you must have started very early, Nino. Nino has been the Chief Executive and Executive Director role since 1991, managing a range of metropolitan rural hospitals and health services, residential aged care services, disability and accommodation services, and ambulatory and community health and aged care services as well. Nino is here as the chair of the Northern Community Health and Research Foundation, and it gives me great pleasure to welcome Nino to the podium just to talk a little bit about the foundation. Thank you.
Thanks very much, Andrew, and welcome all this evening. It's a great pleasure that I'm here on behalf of the Foundation to welcome to their public lecture. The Northern Community Health Research Foundation has been running public lectures for many years, their 19th public lecture event since the Foundation has been established about 25 years ago. Throughout that time, our major focus has been on services and supports to people in the inner north of Adelaide, and through our strategic planning work, we're looking at how we can broaden that support to other parts of northern parts of the state. A lot of our funding is actually attributed to support to communities, but also a close alignment and responsibility and link with the university sector. So since the Foundation has been established in the last 25 years, a lot of the work, as I mentioned earlier, is part of a support to our northern communities through the councils of Prospect, Walker, Port Adelaide and Nuffield, but focusing on health and aged care related research and activities. We invest a lot into promoting programs, better health outcomes for the northern community, and partnering strongly with local government and other key organisations involved in the health and aged care sector. In the 25 years, we've actually invested $5 million worth of funds into a variety of programs, and in addition to that, the seeding funding we provided has resulted in over $10 million of additional funding into the national research outcomes. We've supported over 100 programs in that time, and as I mentioned, this is the 19th of the visiting professor programs here in South Australia. The association with the university is really strong, and we're really grateful for their support and the work we're doing together. It takes me great pleasure in reintroducing Andrew back to the podium. Thank you.
Thank you, Nino. It really is, like I said to you earlier, it's truly an honour to be here this evening and to actually introduce our speaker this evening. The visiting professor and our presenter this evening has been supported to come over to Adelaide and spend a couple of weeks here with us by the Northern Community Health and Research Foundation. So for that, we're very, very grateful to the Foundation. It's the 19th, am I right in saying the 19th visiting professor that we've had that's been supported by the Foundation. And I think it's really an example of where the Foundation's impact is shown by the opportunity to have somebody of Professor Salazar's expertise and international reputation come and visit us for this period of time. So Professor RAFAEL Salazar is Director of Medical Statistics in Primary Care at the University of Oxford and has spearheaded the development of a highly esteemed methodological statistical team in the United Kingdom, with a special focus on multimorbidity and monitoring of long-term chronic conditions. Since 2008, RAFAEL has led the Monitoring Long-Term Conditions Group, making national and international partnerships in the United Kingdom, Europe and Australia to develop a new series of evidence-based methodological tools to improve primary care guidelines. RAFAEL has published an astonishing 250 publications, 27 editorials, 5 chapters and book series, and as a researcher, RAFAEL has attracted over £40 million in grants, of which £18 million as a principal investigator. So it's an incredible achievement over that career. He is currently working on research projects exploring the role of artificial intelligence in supporting the management of multiple long-term conditions, methods to support decision-making in integrated care boards, the identification of groups at high risk due to extreme temperatures, and the development of new diagnostic tools for the primary care settings. In this evening's public lecture, RAFAEL will talk about the impact of multimorbidity, the challenges to the healthcare system, and some opportunities to reduce the burden of multimorbidity in the future. So please join me in extending a warm welcome to Professor RAFAEL PERERA Salazar.
You can hear me okay? Perfect. So good evening, everyone. Thank you very much for being here. I want to start off by expressing my deep, heartfelt thanks for the support that the Nuffield Community Health and Research Foundation has given me and has allowed me to be here with you, presenting not only the opportunity to talk to you today, but also to have general conversations with many researchers across the University of Adelaide and across other health resources that exist both in Adelaide and also in the rural communities. It's been a real eye-opening opportunity, and I am sure that it will allow me to move forward with new collaborations across the University of Oxford and the University of Adelaide, and also different healthcare systems. I've seen different approaches that you guys are using and taking, and some of what I'm going to be discussing today could actually be solved potentially by these approaches that I've seen. So the presentation today, the other thing, sorry, I almost forgot to thank Professor Sanatino and particularly Professor Gonzalez-Chica. You have a very, very special person with Professor Gonzalez-Chica. He's been an absolute gem, allowing me to not only understand what's happening, but also creating, as I was saying, a series of meetings over these couple of weeks. So thank you very, very much, Dan. The talk today will follow roughly these 4 steps, these 4 themes. I'm going to tell you a little bit more about the transition that we've had over the years from communicable to non-communicable diseases. What has that meant in terms of how healthcare is practiced? As part of that, then extended to understand what we mean by multimorbidity, to the definition, which is not actually something set in stone yet, and probably never will be. The challenges that multimorbidity management bring to the current systems that we have in place, and an approach that we're proposing as a way of managing this particular situation. So let's start by saying that multimorbidity is actually a story of success. Success in the sense that we have moved in 120, 130 years from a situation where mostly infectious diseases were the leading causes of mortality and morbidity across the world, things like flu, tuberculosis, gastrointestinal infections, to a situation where these are mostly solved. There's still some situations where these are incredibly important and present, COVID being one example of that. But generally, by 2010, most of these infectious diseases have been replaced by what we call non-communicable diseases, things like cancer, heart disease, and cerebrovascular disease. By 2019, the main causes of disease, both in terms of mortality and specifically morbidity, were cardiovascular, cancer, and chronic respiratory disease. you see the massive change in the proportion of mortality that we had in the 1900s compared to 2010. Mortality or early causes of death, and typically this is referred to as mortality happening before the age of 70, has decreased significantly. About 50, but more than 50% of the causes of mortality have been reduced. The other thing that I want to highlight from this slide is to show the changes that have happened in the causes of mortality. We've moved again from things like gastrointestinal infections, tuberculosis, and pneumonia being the leading causes to pretty much disappearing as the cause of mortality and morbidity by 2010. That's in the US. Globally, from the 1990s to 2019, we can see the change as well in terms of the types of conditions that rank highly in terms of the impact on mortality per large numbers of populations. Here we had in the 1990s still respiratory infections, maternal and neonatal infections, and enteric infections appearing quite highly in the rankings globally. And 30 years later, they've actually important advances, particularly in the areas of maternal and neonatal health and enteric infections, have managed to move these conditions, the types of conditions, lower down the rank, replaced by things like diabetes, digestive diseases, and neurological disorders. And this has meant a massive improvement in the life expectancy globally. Here we have a slide showing life expectancy in the UK between men and women appearing at the top and the men in red at the bottom. The two things I want to highlight is the near linear association or relationship over time in the increase in life expectancy. This is up to 2016. We think that that's actually tapering down a little bit. It's actually been potentially a little bit of a reverse due to other conditions that have happened, particularly in the UK. But there's been a general increase, certainly over the last 30 years, 40 years, 100 years, in fact. And the other thing that I want to highlight here is that that increase is not happening at the same rhythm between men and women. So men started on a much lower level of life expectancy compared to women. And as time increases, men are catching up. And this is mainly due to improvements in the type of support and health management in men's conditions and the lack of support in women's health. But life expectancy is not the only thing that we should be focusing on. We should be focusing particularly on healthy life expectancy. That is the time that we spend without any conditions. And this slide is showing you the expected time that we have with healthy life expectancy. In the case of the UK for women, in 2000 it was at 62.5 years. By 2014 it was 64 years, so a gain of 1.5 years roughly. But I want to highlight here that the number of years that's spent on poor health has increased in relative terms in a much greater proportion compared to what we have in normal life expectancy. So an increase of one life in poor health, which is actually showing that although we're living longer, more of the time we're spending it managing ill health. One critical aspect is that this is not completely consistent across regions. And these differences between regions, as we can see here in healthy life expectancy between England, Northern Ireland, and Wales, could be due to multiple factors. Understanding variation is like bread and butter for me as a statistician. It's important in finding out what's happening, but more critically, it provides us with potential opportunities to understand why these differences occur and try to minimize these differences to increase the life expectancy and healthy life expectancy across the different regions. What's happening in Australia? Well, in Australia, it's a very similar pattern to what's happening in the rest of the world. If we look at life expectancy at birth, there's an increase almost linear over time, starting from 82 years, a little bit more than 82 years for women in 2000. In 20 years, has an increase of nearly 3 years of life expectancy. That is, in terms of the rate or the differences between men and women, similar to what was happening in the other slide that I was showing you. The men life expectancy was around 77 years, now it's 81.3. So the men are catching up. And the healthy life expectancy, interestingly, this is information from the WHO, shows an increase, similar in the sense of a greater proportion of the time gained is in ill health. But critically, in the last year or 2 years, there's been this drop, which I don't know why. I never really seem to hear in some perspectives as to why this healthy life expectancy in the case of Australia has reduced in the last year or so. But generally, what I'm highlighting here is that we spend a significant amount of time, in the case of women, actually a significantly larger amount of time compared to men, in ill health. So what has happened in relation to the risk factors associated with ill health? Here we have the changes of the risk factors over the last 30 years, from 1990 to 2019. And what we can see generally is a trend downwards. Most of the risk factors, the communication about these factors being a risk for multiple diseases has actually been quite effective. Reductions, particularly in things like air pollution, has been massive. Tobacco, high blood pressure, even things like diet. The one that has completely dropped off from the main factors has been unsafe sanitation, fortunately, has been a massive, this at global level, has been a massive improvement. But instead, what's being replaced by is the fact that we have high body mass index. So it is well understood that as we change our diet, but BMI being a critical risk factor for many conditions, including cancer, obviously cardiovascular disease, is becoming more and more prevalent. So here's a bit of a snapshot looking at all these different factors. The last one that I want to highlight from these factors is the fact that temperature at the bottom hasn't really changed that much. So it's remained relatively stable over time. But that might change, particularly with these new understanding of how climate change, particularly extreme temperatures, are affecting different types of conditions. But conditions, chronic diseases is not a thing of new. Chronic diseases have been here for a very long period of time. So we go back in history and have a look at records from the Civil War in the US. We can see that there were huge levels of arthritis, heart disease, and cancer at early ages, to the point that recruits under the age of 20 were rejected on medical grounds. 16% of those were rejected on medical grounds. 25 of those between 20 and 25, and nearly half of those in the 30s. So people were living with chronic conditions then. They were not maybe dying with those chronic conditions because other infectious diseases were coming in and being more important in causing mortality, but certainly people were living with chronic conditions for a long period of time. There was a comparison of these individuals that lived in the Civil War with their great-grandsons. Okay, no worries, no worries. That fought in the World War II. The generation that lived on the World War II generation lived on average 8 years longer after adulthood. So this increase in life expectancy, but significant amount of time is spent with debilitating illness, certainly in the case of the Civil War generation. So it is not, in a way, chronic disease is not a new thing. It has been there, but it is much more related now to mortality and certainly to morbidity, as I will explain in a minute, regarding the fact that we're living for longer. So what is multimorbidity? Multimorbidity can be defined in several different ways. I'm just going to give you a couple of definitions of multimorbidity. There's no a single definition. Probably the one that's most commonly used is this one, the coexistence of two or more chronic conditions, each of which could be, and then that's it. The existence of two or more chronic conditions, that's the definition of multimorbidity. The Academy of Medical Sciences goes a step further and says, well, these conditions have to be a physical, non-communicable disease of long duration, such as a cardiovascular disease or cancer. It could be a mental health condition of long duration, such as a mood disorder or dementia, an infectious disease of long duration, such as HIV or hepatitis C. So chronic in the sense that it's there, it's unlikely to change. And the important thing here is that it could be a very long list of potential diseases. Compare this to a publication from Larester, which said that multimorbidity is defined as a combination of chronic with at least another disease. It could be acute or chronic, or a biopsychosocial factor. That could be, for example, poverty. Multimorbidity may modify the health outcomes and lead to an increased disability or a decreased quality of life or frailty. So this is similar, but it's not exactly the same. And the definition of multimorbidity hasn't been sort of set in stone. There was a discussion a couple of months ago, sorry, where a group of international researchers, particularly focusing on multimorbidity, said, well, how about if we come together as a group and define it for once and for all? But this has been tried several times. So that same group rejected the idea simply because it's not necessarily a bad idea, but it's very difficult to actually make it work. So it creates some very important challenges, the fact that we don't have a clear definition of multimorbidity. Worse than that, we don't have a definition of disease. So this might seem really funny, which it is, but in a way it highlights the problem that we have in the definition of what is an illness. So let's look at some examples of people or individuals that we would regard as having some form of multimorbidity. A woman, age 42, goes to the doctor, has been feeling unwell. Their HbA1c measurement of glucose level in blood is taken, and they identify her as having diabetes. She gets very anxious about the label. In the past, when she was 12, she was diagnosed with asthma, but she had been taking her inhaler and had managed very well her asthma. She was completely in control. But now the diabetes might be actually bringing some degree of instability to her whole management. Compare this to a 65-year-old who suddenly turned up, was diagnosed with having, in a routine blood pressure check, was identified with having a systolic blood pressure of 155, which is above the threshold that we use of 140 to diagnose hypertension, gets given some medication. Her blood pressure in that phase of the initial treatment, the drug is actually too high, which means her blood pressure is actually reduced significantly, which leads to her falling and fracturing a bone. She goes back into to the care of her clinician and is diagnosed with osteoporosis that hadn't been actually identified earlier. Final case. This man at 45 is identified with an enlarged prostate. He feels anxious, so he starts taking spirits in order to reduce the anxiety. 5 years later, he's seen as having high blood pressure, that's at 50 more or less. 51, 52, he's diagnosed with diabetes. Later on at 65, he gets Parkinson's, and finally at 72, he has chronic heart failure. That seems a bit excessive, but if we live long enough, maybe not at that order, but if we live long enough, we would accumulating all these different diseases. So we will be in a situation similar to this man more often than not. So we agree that those are examples of multimorbidity, but the definition of multimorbidity makes it itself quite challenging to research in the first place. What I'm showing you here is a graph of multiple studies, each one of them appearing in different colors. So you have a BT 2004 in sort of dark blue, you have a CADAM 2007 in purple, you have Nassim's 2011 in, let's say, orange or mustard, it's called. And each one of these studies, reflected in different colors, identify the prevalence of multimorbidity by a different age. So let's say in the case of Barnett, which provides information from multimorbidity across multiple ages, the chances of having multimorbidity in later age, let's say at 80, 90, close to 100, is nearly 80%. While for the case of a 20, 30-year-old, you'll be around 50%. Straightforward. The thing that I want to highlight here, twofold. First of all, that the studies themselves show massive variation in the amount of multimorbidity identified in each one of these studies. So there's going to be a lot of differences regarding the prevalence for a given age. This could be because these studies have been carried out in different populations, in different countries, but more likely it's because they're using a slightly different definition of multimorbidity. Some might use a definition that lists only 10 conditions. Others have a list of conditions that have 140. Simply because of that, you're going to end up with a greater chance of having multimorbidity if it's a study with 140 conditions compared to a study with 10 or 15. The other thing I want to highlight, which is generally obvious, is the fact that the prevalence of multimorbidity increases with age. So as we get older, we accumulate more and more diseases, or the chance of accumulating diseases increases, and therefore it's been proposed that multimorbidity is an issue of older age, not necessarily of the young. And most of the analysis, most of the research that we're doing in multimorbidity has that as a premise, thinking about managing multimorbidity later on rather than managing multimorbidity earlier on, which is something I want to come back in a minute. What's happening in Australia? This is from the Australian Bureau of Statistics based on a survey. So this is self-reported data, asking individuals whether they had a chronic disease or not. And as you can see, around 50% of individuals that responded had a chronic condition, and around 20% of them would have multimorbidity. This is across all ages. What are the conditions that have been mainly reported? Chronic obstructive pulmonary disease, COPD, heart, stroke, and vascular disease, so cardiovascular disease of some form, cancer, kidney disease, osteoporosis, diabetes, arthritis, back problems, asthma, and mental health. So this is a really good spread of the different types of conditions that we're likely to see. And the interaction between them, for example, if we have COPD and asthma, maybe there's similarities in terms of the management. If we have COPD and a mental health issue associated with that, depending on what mental health that happens to be, if it's anxiety, it is what would be expected. If it's bipolar disorder, it isn't. And then the management could be significantly more challenging. Same survey, the association by different ages is what we expected. As we look at different age groups, the prevalence of multimorbidity increases with age. But critically, multimorbidity is not the same if you look at those that are in the younger age group compared to those that are in the middle age group and those that are elderly. This is a paper from 2020 that looked at creating clusters of multiple conditions based on different age strata. They created 4 age strata, 18 to 44, called young, 45 and 64, young elderly, 65 and 85, elderly and very elderly, 85 plus. They have your different groups. And they worked out what would be the most common conditions in each one of these strata, focusing specifically on multimorbidity, more than one condition. We talk already that the prevalence is higher as we get older, but what about the different characteristics? What are about the different conditions? And here I want to highlight the 2 extremes. So the 18 to 44, the main clusters, the main conditions that grouped together were depression, anxiety, and pain. Second one was pain, hearing loss, hypertension. And then the third one, asthma, IBS, and depression. So the one on the left is the one that appeared the most in that particular cluster. So that's how they define that cluster. For the very elderly, 85 plus, the main condition was hypertension with hearing loss and diabetes. Second cluster was pain, depression, and constipation. So in the presence of multimorbidity is not exactly the same when we look at multimorbidity in a young population compared to the elderly population. So even the label itself might be problematic. We know, for example, that most of the conditions that appear in the young have a genetic or hereditary component. Compared to conditions that appear in the very elderly, they tend to have been much strongly associated with the risk factors that we're talking about before, things like exposure to high BMIs, to smoking, to drinking. So when we talk about multimorbidity, even saying multimorbidity in general might not necessarily be the case, and we need to be thinking about where we are. And this is a final slide that I want to show regarding the transition between different patterns of multimorbidity. This is looking in Sweden at an elderly group, I think it's 65 and older. So it's a population mainly of older adults, followed over 12 years with groupings of the different kinds of clusters that they exist. So the first one was psychiatric and respiratory disease, heart diseases, eye diseases, and cancer. You'll see that the biggest majority, and this happens regardless of which type of methods we use, is the unspecific, the ones that is other. But here what I want to highlight is the transition that is represented by the different colors moving across the different clusters. And as you can see, the clusters are not static. On a relatively, not necessarily a long period of time, 6 years, 12 years maximum in terms of follow-up. So we've moved on a little bit in our thinking between multimorbidity. Instead of focusing much more on the cluster side of things, representing what's happening, we want to try to understand a little bit more what are the trajectories of individuals, and thinking that it's precisely not a static problem, and ideally identify through those trajectories if there's any way of actually including some form of treatment aiding prevention. Final thing that I want to highlight from the survey carried out here in Australia is a critical issue that multimorbidity is strongly associated with socioeconomic level. The most disadvantaged, which are the ones on the far left, have a level of multimorbidity of close to 30%, while the least disadvantaged have a level of multimorbidity close to 15%. So it's a 15% difference, maybe a bit less, but it's significant, and it's a gradient. Critically, the way we understand this is that it might be that the same type of clusters, the same type of patterns of multimorbidity appear, but the time that they appear is significantly different, with something between 10 and 15 years earlier, in the case of the most disadvantaged group, these patterns appearing compared to the more advantaged. So it's an issue of equity, equality as well. And as you can expect, the economic burden of these type of issues is significant. In Australia, chronic disease causes 9 out of every 10 preventable deaths, suggesting preventable deaths, again, thinking of people dying before the age of 70, accounting for 85% of years lost due to ill health and early death. In total, the health system spends spending due to potentially avoidable risk factors was in the order of 24 billion. And the usual suspects appear: overweight and obesity, and obviously tobacco use. And this is likely to just get worse. So here is looking at the demographics of Australia now and where we're going to be in 2050. And if we're talking about multimorbidity being mainly an issue of the elderly, the pyramid, demographic pyramid, suggesting that we're going to have many more elderly in Australia, means that this is going to be even more challenging. And it's comparable to where Japan is at the moment, just to give you a rough idea of the transition that we're expecting over the next 25 years. The question is, okay, we have multimorbidity, it's a problem, are we good at managing this? And the answer, as a researcher, is we don't know, and it depends. So I'm going to go back to the 2 examples and try to understand, based on those 2 examples, we agreed that I agreed with myself that there were cases of multimorbidity. And let's think about how that management would happen to be. So this is a case of a woman that was diagnosed with diabetes relatively not that long ago, had asthma that was well controlled, and now is anxious. Well, we have good treatments for diabetes. Her asthma was well controlled. If the diabetes is well managed, then it's likely that also her anxiety will reduce. So potentially she will be in a relatively straightforward management plan. Compared to this man that had multiple different diseases, in fact, some of the interventions that we're using, some of the medications are actually impacting on the other conditions that he has. So his management is incredibly complex, incredibly challenging. So that's why it depends. Again, multimorbidity is a label that is being used to consider, in a way, very, very different syndromes, very different scenarios. So one potential approach, and again, being a statistician, I apologize for the fact that I'm focusing on a quantitative measure in order to manage chronic diseases. I love this phrase: know which abnormality, in this case of chronic disease management, know which abnormality you're going to follow during treatment, pick something you can measure. So if you have high blood pressure, it's relatively straightforward. I'll just follow your blood pressure. If you have bipolar disorder, that might be a bit more challenging. There are multiple measures. In the case of systolic blood pressure, it's relatively straightforward. These different types of levels of measurement have been proposed. We can think of based around aging. If we think of multimorbidity being associated with aging, we can think of aging or measuring aging in different manners in terms of function. So we can think of cognitive function, physical function, mood, mental health. We can think about phenotypes like body composition, energetic, somastatic mechanisms, brain health. We can think generally of biological aging at cellular level, molecular level, repair, telomeres. So depending where we want to set up our measurements, our parameters, we might end up with very different systems. The system that I want to use is mainly based around measurements that we're currently using already. So if we think of disease as a label, the characterization of disease, the diagnosis of disease, is based around our understanding of where is the health state of that individual at a particular point and where they're going to be over time. So diagnosis and prognosis. And typically, this is based around either clinical markers, imaging, or syndromes. Clinical markers in the face of things like I was saying, systolic blood pressure, cholesterol, or HbA1c. If we use these types of markers, we can also think of management of conditions, but from the perspective of advanced screening. So identifying strategies to work out where these individuals are going to be later on in life. And based on that, create preventive models that should be tailored, obviously, to the individual based on where they are at a given time point. This is an area of potential opportunities. We can think of this being an area where basic translational, clinical, and services could interact with health services saying, this is something that we need, and basic science providing some of those answers. Part of the big challenges is that basic science is presenting many alternative options or solutions that are not necessarily needed or wanted in the face of health services. So there's a bit of a disconnect, and having people translating what the requirements are and what the possibilities are is a major aspect of potential improvement in the near future. Going back to biomarkers, let's think of defining or how we define disease. In the case of going back to systolic blood pressure, we can think of a threshold up to which individuals are determined as being out of normal. So in the case of systolic blood pressure, we talk about a threshold of 140 millimeters of mercury. The same thing happens for other types of conditions. For example, diabetes. If your HbA1c is above 6.5 or 7, then you are diagnosed with having diabetes and you're meant to be bringing those measures back. But there's not only those two, there are many other conditions where we use, for example, in the case of asthma, we can use FEV1, and you can generally think of many others where you could potentially use different biomarkers, not all of them, as we're saying, but many of them to be potentially used as a way of managing chronic diseases. One of the big challenges, though, is that in our healthcare system, certainly in the UK, and I think still most of Australia, most of these diseases are managed by specialists. And the management of specialists focus on a single condition rather than necessarily all the conditions at the same time. Instead, and this is a paper that we published in 2014, one of the potential approaches is, or what's actually happening, sorry, is the management of the individual on the multiple conditions based around generalists. So by that, we mean both GPs, general practitioners, and geriatricians. And the conversation between the geriatrician, the GP, the patient, based on what are the patient values at a given time, is necessary in order to determine what are the next steps to take, what are the treatments to use, which treatments not to use as well. So this figure, what is highlighting is the fact that it could be someone in control. There's going to be a new trigger, a change in the disease, a change in the context that triggers some form of interaction, some form of assessment, sorry. As part of that assessment, that will be jointly between the clinician and the patient, the determination of what are the goals required as part. It might be a change. It might be, yes, I want to control my blood pressure. I want to control my cholesterol. More likely it's going to be, I want to not have pain in my shoulder. Most likely it's, I want to be able to go to the toilet on my own. So it's going to have to be a prioritization of patient's preference and therefore individualized management. So this is the idea from a generalist perspective. But it presents important challenges. Who defines the targets and goals? How do we encourage new and better practices? How do we improve our understanding of what's actually happening to the individual? In a system, and this is definitely the case in the UK, I'll show you in a slide some of the numbers, in a system where the person-doctor interaction is at stretching point. I think this is also the case here in Australia with attendance being able to access your GP being incredibly more challenging. We did some work trying to understand the increased workload the general practice practitioners are on. And as you can see, all these markers is a general increase in the workload of GPs. The amount of resources allocated in general practice is actually decreasing. Everything from clinical consulting days, number of consultations per person, the number of consultations by phone, face-to-face GP consultations, and the duration of each consultation was going up. And it is a stretching point to the point that before I left from the UK, it appeared in the news that GPs were only going to be working to the time they were paid. So they're no longer working extra hours. So what can we do about it? One potential approach is the use of different types of devices. These are becoming more and more common, not only in general practice, not only hospital and in general practice, but nowadays even in our homes. Many of us probably will have a blood pressure machine available to track our blood pressure. If you're diabetic, you probably will have also a blood glucose reader or based on HbA1c. And things that allow us to read your FEV1 are also available. So point-of-care devices are already available. Many people are already using, and we can using them. And we can use these devices in order to work out what is my normal, what is the new process. And based on that normal, we can work out if our trajectory over the last 4 years is stable or if it's changing significantly. And if it's changing significantly, we can potentially do something about it. Decide that this is not a trajectory we want to follow. We want to do something different. And this decision can be made, ideally, in combination with your clinician, but more and more individuals are deciding to take over and making these decisions themselves. And just like we have it for systolic blood pressure, we can think again, using these potential biomarkers on multiple conditions at the same time. But one of the key challenges is that potential information that is now available for the majority of us when we go to the general practice, that information on systolic blood pressure, information on cholesterol levels, information on if we are diabetics on HbA1c, information if we're asthmatic or have COPD or FEV1 or some kind of lung function are already available. But we don't really know, for example, who should be checking these trends, how should we be interpreting, what should we do based on this information? This type of data is not really available yet. It's done certainly, but haphazardly, typically by specialists in each one of these different markers, different diseases. As I was saying, this is sometimes done by generalists or more likely by self-management of the individual. So one of the things that I'm proposing, and I think this is the movement that most of these records are currently available, is towards an integrated system that's able to use that information and present it in a much more digestible way, both to the clinicians and to the patients, so that they can make informed decisions of where they want to be in the near future. But, as I was highlighting, not all conditions are managed this way. I would say yet. In reality, might never be managed this way. We know, for example, that cancer and mental health are very challenging, but there are new markers of these diseases that are becoming available. Not that long ago, we were involved in a study looking at multiple cancer blood detection tools. And the idea was that these type of devices or these type of tests were going to be able to detect not only if cancer was present, but specifically the place where the cancer was appearing. Currently, they're not very good. So they do detect if cancer is present, but they can't work out where it is. The sensitivity and specificity, the accuracy of these tests are not there yet. But that's where we're going towards. The use of other types of biomarkers to detect of long-term conditions, specifically cancer. And similarly for mental health, there's some measurements that have been proposed based on blood readings. But alternatively, we can use different modalities of measurements. For example, in the case of mental health, the information that's been provided by an individual at a given time point might be incredibly useful. There was a trial where people with bipolar disorder had to enter daily a score of both their manic scale and their depressive scale over time. you probably will not be surprised the most important signal was when people stopped responding, because that's when they went into manic phase. Alternatively, there are also some advances in imaging and alternative sources of data. And I want to highlight that omics is being proposed as an alternative source of information, but I haven't done any work in that particular area. Now, critically, one thing that I find particularly relevant when I'm talking about looking at measurements over time is the issue that if you go on looking, you might find things that are there, but are not affecting anyone. They're not actually being a problem to the individual. So in this slide, I'm just, that I borrowed from Professor Paul Glassier. This is a very well-known example of what we call over-detection. So just before 2000, there was a thyroid screening program in South Korea. And based on that, the number of cases of thyroid cancer increased massively, as you can see in the blue line. What you almost cannot see is the pink line, which is the thyroid cancer deaths. It basically shows that there has been no change in cancer. So it's not that there was an epidemic, it's just when they went on looking and then they detected maybe what we call incidental. So when we talk about overdiagnosis, really what we're trying to work out are those individuals that are in the rabbit zone. Those are slow enough so we are able to detect that a change is happening and that change will be relevant at a certain moment in their life. If they're hummingbirds, they're going to grow too fast. We won't be able to do anything about it. If they're very slow or not progressive, again, it's not going to be of any impact. Well, if it's very slow and we actually measure them, it's not a problem. If they're very fast or non-progressing, then we might be able to actually identify them simply because of the error in the measurement, identifying them without necessarily being able to do anything about them. So my premise is that we are at a threshold. We are collecting vast amounts of data. Information is already present from us in records. We are also collecting information ourselves. We need to have this information better presented to us in a way that is actually meaningful, that we could make use of this information and have these conversations if you guys are clinicians, and even if you are patients, have these conversations with our clinicians to decide what is most useful, most important for us in terms of our management of ill health. And if we have identified trajectories, we can think not only of managing ill health, but we can think of doing this earlier on while we are not diseased. So working out our trajectory earlier on and identifying our lifetime trajectories when you're still healthy. Thinking about what is my average systolic blood pressure? Is it going up? Should I do something about it? What is my cholesterol level? Is it going up? Should I do something about it? And many other things, but integrated, not in isolation. And as I've been highlighting, this is already happening. So many people have different types of technology that allows them to detect or identify different important biomarkers or different important signs and symptoms in their body. Things like their heart rate, things like blood oxygen levels, breathing rate. So if you have an Apple Watch, you have a Fitbit, you have a heart rate monitor, all of those things will allow you to detect critical important biomarkers. The Aura ring is another example of that. But these are expensive. These are options that are available for those that have money. Increasing the disparity, increasing the levels of the differences between those that have and those that do not have in terms of the appearance of multimorbidity and the management of multimorbidity. So, in conclusion, multimorbidity is a problem caused by the success of, I would say, modern medicine or modern life. The definition is roughly the appearance of two conditions that interact with each other. I'm proposing that the management could be based around measures and definitions of control. It could be based around biomarkers. It could be based around other types of measurements. And the idea is to extend this to all conditions. This already happened. The idea of the definition of control is already happening to multiple diseases. But my intention is that this is extended to all conditions, ideally. But for that, we will need novel ways of identifying the different conditions and managing this information. That we should move, instead of managing multimorbidity, into a paradigm where we're managing health, that these tools exist, but are in the hands of those that have money, and therefore a new social contract required regarding the collection of information, how personal data is going to be used, with what sort of intention, and the information that's provided as part of that, created as part of that, in regards to interventions, how that's going to be presented to individuals. So let's finish off just with a couple of quotes. The first one is, "My interest in the future, because I'm going to spend the rest of my life there." So I've been working on this for the last 10 years, still a work in progress. And the slightly less flattering one is, "Old age isn't a battle, old age is a massacre." Thank you all very much.
Thank you, Raphael, for a thought-provoking presentation. I think it is I think you raised a number of really key issues about how we deal with what is a tsunami of aging in effect, and how we deal with that and the cost of addressing those areas of multimorbidity in the community. This actually is a time when we ask our audience to participate, and we'll have a number of roving mics, I think, and I'll also do the roving mic thing as well. And you can feel free to ask questions of Professor Salazar on this particular topic. So, questions from the audience? Well, I might break the ice in that case, if that's okay. So, Raphael, one of the things that you address is, obviously we're now seeing increasingly the diagnosis of multimorbidity in our community. One thing that we know is that with individuals with multiple health conditions, it becomes a challenge as to which ones you treat in preference to others.
Yeah.
Does any of the work that you've been doing give us a sense of those particular maladies that would take precedence in the treatment regime or the treatment schedule?
So there's two answers now.
Yeah.
The first one is based around patient preference. So from that perspective, having that conversation, that dialogue, or opening that dialogue to say, okay, these are all different things that's wrong. What is the most important to you? That seems to be generally what we're proposing as a way forward in terms of just the management from the perspective of journalists. Having said that, regarding the types of conditions that we see are particularly strongly associated, but once you have one, those seem to be critical in terms of developing multimorbidity. Diabetes, unfortunately, seems to be the most critical one. But once you get diabetes, almost always we get second, third type of condition. So if we were able to actually manage the tsunami of diabetic cases,
Yeah,
spreading across, well, partly because of high body mass index. So the obesity is also strongly associated with that particular condition.
Thank you. Are there any questions? Because I've got plenty here. I've got teams that are great.
Thanks, Raphael. I've heard you say several times since you've been here that you're a quantitative statistician, you know, very it's numbers and counting things.
Yeah.
Yeah, that last answer really strikes at the heart of my clinical activities as palliative care physician, and that what you're saying is it's patient preference. Well, that's an advanced skilled communication with ethical sort of frameworks of not coercing, but actually informing and helping people make decisions when they're potentially quite vulnerable. And yet you've told us tonight that GPs in the United Kingdom are you know, more and more stressed, more and more busy.
Yeah.
And I know we're doing lots in our university to try and encourage our medical graduates to see a career in general practice as something that's worthwhile. Which is all of a comment, but it seems to me, you know, Andrew's question about does one disease drive the decision making? And our health system, you see it in acute hospitals, often it's the ones to get treated and then the next admission it's the heart. And yet what's the quality of the evidence that we have to help us make decisions for somebody who's got several diseases all at the same time? Because, you know, are they all 50-year-old men that had one disease? That was the level of evidence that helps us make decisions about what's the right blood pressure and what's the best diabetes control.
Yeah. So the generation of evidence for multimorbidity is particularly challenging. So what you were saying about which condition to treat first. Guidelines are not going to be able to tell us that, simply because the syndrome or the number of conditions is going to be quite different from one group or one individual to another. The generation of evidence, as I was saying, tends to focus on single conditions, particularly if we're looking at things like trials. Sometimes when people are presenting, oh, I'm going to look at multimorbidity, it's going to be diabetes and heart disease, or it's going to be diabetes and COPD. That tends to be the focus. So again, the generation of evidence is mainly from single conditions. In order to generate evidence for multimorbidity, I think we need a slightly different approach. The use of electronic health records is probably the only way that's going to allow us to at least get a handle of that. And we know that it's very biased as well. So that's another major challenge. My take is I would be in the ideal scenario, I could think of situations where the information is available in such a way that you can identify where you are compared to other people like you, similar to what you have, let's say, in Amazon, let's say. So people like you with these diseases and these medications went on to have these other conditions. So let's try to stop that. Let's think about what you can do instead. So that's what I would envisage the integration of electronic health records with decision making and the clinician to go towards.
Thank you. Excellent talk. Thank you so much. I wonder whether, in terms of trying to define multimorbidity, we're actually asking the wrong question. You know, it sounds a bit like, you know, trying to kind of find a cure for cancer. That was what we sort of aspired to do 30, 40 years ago, whereas now we think of cancer as having a whole bunch of different factors. And I just wonder whether that's the case with multimorbidity, you know, in terms of just doing a disease count or a Charlson sort of index. A lot of work's been done looking at clusters. So particularly when you're sort of talking about diabetes being an important factor, that's often very important in the sort of cardiovascular, cardiorenal cluster. I just wonder if you have any comments on insights into how we can break up multimorbidity into different groups and look at it in different ways.
So that's actually a position where I think we're getting towards. There's still a perspective. I actually raised exactly that point, saying, well, look, what we have is all these different diseases. There are labels, again, labels that tell us where this individual happens to be, and it gives a good prediction of what's going to happen in the future. But when you're talking about multiple labels potentially interacting, those labels might not necessarily be useful anymore. And for those individuals, you might need different labels. And multimorbidity is still using the same labels, but slightly rearranged. So my take was, well, again, thinking out in the example of having different types of clusters between multimorbidity in the young, multimorbidity in the elderly. My argument was, well, multimorbidity is not the same thing. Maybe we should be focusing a little bit more on understanding what's happening in the young, and maybe understanding a little bit more what's happening in the elderly, and maybe the terminology might not necessarily be as adequate. But there was a big pushback saying, no. We know that it's important because when you move from 2 to 3, the risk increases, and when you move from 3 to 4, the risk increases, regardless of what we count. So we're at that stage that people are at least beginning to think the definition of multimorbidity is insufficient to actually move the research in the direction that we want. And there's a lot more work on the area of trajectories, trying to understand, okay, what is a natural progression? And where they're likely to be. So I think that's, well, my bet is that that's where most of the advances in this area will happen.
Thanks, Raphael, for a great presentation. I'll allow for it.
Everything is working.
Oh, it's working,
Yeah.
great. Raphael, thanks for a great presentation. Just towards the end, when you're talking about integration of electronic medical records and tools to look at that better, I think Australia is lagging on the integrated medical record concept, certainly between primary care and tertiary care. And I wondered if there's anyone who is more advanced in this space that we could sort of be looking to, who's starting to use longitudinal data in an integrated way better.
In terms of clinical management, the UK is pretty much in the same situation as Australia. So the systems don't talk to each other, which is a big problem. I remember when I first started in primary care, there was this big talk about the new electronic health record system for the NHS that was going to solve all the problems, and then quietly disappeared after about 5 years. So it didn't happen. So there's a big need for that, for sure. I imagine places like Scandinavia might have slightly better systems. We know that the registries that they have are actually more certainly useful in terms of research. Whether they have the right setup in terms of integration between hospital and primary records, I do not know. But I definitely think that that's where we should be aiming towards. It's going to be challenging. It's one of those situations like, what should I do? Well, I want to start here. So unfortunately, that's the case. But I know that there's some initiatives at least to start thinking in the research area at least of how it could bring some information together from hospital and from primary care, which that's already available in the UK, but with a significant time lag, so it's not necessarily useful for clinical management.
Right, while we're waiting for people to come up with some questions, I might just look at the idea of monitoring and vigilance and screening tools that have been used with biomarkers such as PSA. There's a move increasingly against seeing these instrumented across the lifetime of care, given that there is like you showed us, there's an element of overdiagnosis. There's a risk in regard to doing that and changing policy after we've taken a social decision to implement public health policy like screening. Do you think, can you just highlight what you think are the big risks, if any, of sort of leading to a circumstance where we start to underdiagnose those conditions, which we do have very good evidence to suggest if we detect early, we have better health outcomes.
Yeah, it's a really tricky balance because you're completely right. There's been a movement away from the detection and the emphasis focusing on over detection and therefore potentially on the treatment. It is really challenging. There is multiple people working, particularly in the area of PSA, thinking about what should be the right thresholds, thinking about what should be the frequency of the measurements. I think more and more we move into slide towards the idea that these measurements should be aiding in understanding the increased risk, and based on that, also hopefully helping to identify other types of tests that are confirmatory, that hopefully will be less invasive. So I think there's been a backlash. The likelihood is that with anything is that we overcorrection.
I think I have a question. Thanks, Dave.
I'm going to challenge your trajectory notion. Okay, so we have a couple of GPs in the room, so these you get their perspective. But I think one of the main problems of multimorbidity is not sort of trying to determine whether someone's diabetes is likely to get worse or their blood pressure is likely to get worse in terms of trajectory. I don't think that's the main problem that we face in terms of multimorbidity. The problem is someone with diabetes usually is overweight and they don't exercise enough. The difficulty is we already know what the problems are. The biggest problem is trying to engage people in terms of looking after themselves, adapting the right sort of lifestyle measures, and also being able to kind of fund a lot of things they need, right? So in terms of mental health issues, which is very prevalent, trying to get them the right sort of counsellor that suits well for them. So I see the main gap as being the fact that we just can't get the right person engaged in the right treatment and be able to offer the right services. I'm not sure I'm convinced necessarily about the trajectory view. I think the thing about the trajectory is that oftentimes we end up with patients having multiple different problems, and as clinicians, we're often lost in terms of which of these do we prioritize. And what would be really useful about the trajectory point is to know that, for example, someone has mental health problems. If that's left untreated and you don't get proper counselling for that, it doesn't really matter what their renal function is. You just completely ignore their proteinuria, right? There's no point measuring that. So what it allows us to be able to do is to say, look, we can not worry about these things. We can put our resources into the things that really do matter, because I see that as the main challenge. Just want to make thoughts.
Yeah, no, that's definitely the case. So the program that we're working on right now is aiming to create precisely that. So the intention is to use the concept of biological aging and biological age for each one of the systems to determine where you are given your certain age, and also what is your the rate of change. So if it's 1 every year, you're fine. If it's 0.8, 0.9, it's perfect. If it's 2, 3, 4, 5, then there's a problem, right? So if the intention is to have these type of dashboards provided as part of that information to say, these are the things that you might want to discuss. But your first issue, I completely agree with you. There is a significant challenge on all of us to change our behavior. So changing behavior is incredibly difficult. You won't, it's very rare. It happens. We have some trials I have looked at, quick GP intervention to aid smoking cessation and also to aid reduction in BMI using different approaches, but it's rare. Where change tends to happen is when there's a significant event, where, for example, someone has a heart attack, when someone close to them dies. And the idea could be, and this is something is at very early stages, to have that information readily available. So when those opportunities happen, a potential intervention takes place.
Thank you. Just as a means of follow-up, I think one of the things that we do know is that social policy does work. We've seen that in the uptake of the use of seatbelts in driving. We've seen that in the context of smoking cessation. And we've seen it to some extent in terms of the implementation of sugar taxes in some jurisdictions. We've also seen the flip of the retraction of that legislation in some jurisdictions as well. If you had just one idea of social policy area that we could actually impose on our community to lift health, what would it be? It's a terrible question.
I can be very provocative. So a significant tax on fast food.
Yeah. That would have been where I went to as well.
It's a bit of a hanging fruit. Yeah.
Are there any more questions this evening? If not, can I just say a very big thank you to RAFAEL for your generous spirit. You've been with us for a week to about 10 days.
Yeah, 10 days. Yeah.
And given multiple presentations. And I want to thank you for your generosity in giving your time to give our presentation and also to be so generous in answering the questions that were presented to you. I'm also wanting to thank Nino and the NCHRF for their continued support of our visiting professor program. And I also want to thank many of the board members who are here this evening for attending this seminar. And so really shout out.